Good afternoon, everybody. Let's get started. We'll probably have a few people start a little bit later. Welcome to the BC ECHO for Post-COVID Recovery. I'd like to introduce Dr. Evan Kwong and Dr. Jennifer Yao. Also, there is UBC accreditation for this. We'll be tracking the attendance through Zoom. So please enter your first name, your last name, along with your email address in the chat function. Dr. Jennifer Yao is a clinical associate professor and head of the UBC Division of Physical Medicine and Rehabilitation. She has a clinical practice at GF Strong Rehab Center in the Acquired Brain Injury Program and is also the current medical site lead at GF Strong. Her work includes seeing a full continuum of rehabilitation patients from acute care to community and assisting them to improve their function. Dr. Yao has been involved with the planning of the post-COVID-19 care pathways at the clinics at Vancouver Coastal Health and worked collaboratively with the clinicians there. She has also worked with a number of community organizations, including the Heart and Stroke Foundation and After Stroke BC. Dr. Evan Kwong obtained his BSc in Pharmacy and MSc in Pharmaceutical Sciences from the University of British Columbia. After his MD degree from the University of Toronto, he moved to Calgary for his residency in Physical Medicine and Rehabilitation. Dr. Kwong's clinical practice includes neurorehabilitation, including stroke rehabilitation, spasticity management, electromyography, and the diagnosis and treatment of musculoskeletal disorders. He is a clinical assistant professor in the UBC Division of Physical Medicine and Rehabilitation. At Providence Healthcare, he is currently the medical site lead of the Holy Family Hospital Rehabilitation Services and division head of Physical Medicine and Rehabilitation. He also holds consulting privileges at Vancouver Coastal Health in the community, and in the community works at Infinity Medical Specialist Clinic. As mentioned, we will be tracking attendance for CPD accreditation. So please enter your name, full name, and email. At the end of the session, there'll be a post survey form that will be sent out to you. Please take a couple of minutes and fill that out. The next ECHO session will be held on Tuesday, November 9th, and the topic is post-COVID-19 support for persistent disability programs and required forms, presented by Dr. Jill Calder. You'll be sent a form for registration. And then a reminder, Dr. Yao and Dr. Kwong are happy to answer questions as we go along, so simply raise your hand if you have questions.
Thank you so much, Rick, for the introductions, and good afternoon, everybody. Thank you for inviting Evan and myself to do this presentation today on behalf of the BC Post-COVID-19 Recovery Group. So without further ado, we'll go along here. And just so you know that, when we were developing this presentation today, we really wanted to focus on hoping to provide you with some practical clinical tools that you could implement and look at using in your own settings. So we don't have anything to declare as part of this presentation today. So we have four main objectives for the next hour. So we'll focus on neurocognitive sequelae of COVID-19 today, and also look at how you can apply functional cognitive rehabilitation principles and treatment approaches to your practice. Of course, being rehab physicians that we are, we want you to hopefully understand the multidisciplinary approach to care and how you can best utilize allied health professionals when you feel there is a need for your patients. We also want to discuss access to some of the rehab tools and resources, particularly the ones online, so that you could hopefully make your clinic visits more effective. So I want to start off by giving you an idea about what we mean by neurocognition. And, when I first started doing some research into this area, lots of different terms came up. There was neurocognitive, neuropsychiatric, there was a bunch of other terms that came up. But really, if you look at the DSM-5 definition of neurocognition, they break it down into these 6 domains. And these are the type of things that you will hear your patients coming to you with. So it varies anywhere from language functions to more what we classically think of as cognitive functions like memory and attention and executive functioning, but it can actually still incorporate some of the more physical things like visual, perceptual, motor functions, as well as the emotional side of things like social cognition. Both Evan and I will be presenting a case each that will hopefully illustrate in a little bit more detail in terms of how we might approach some of these challenges that the patients bring to you. So with those domains in mind, these are some of the very common symptoms that the post-COVID-19 patients will complain of, particularly from a neurocognitive symptom. I should just remind myself and everybody here that even though we're talking about neurocognitive symptoms today, you should always consider the role that pain might play in how these symptoms come about. So that one physical feature, I think, is still important overlay on top of all of these things. But certainly patients complain about not being able to find the right words, problems with memory and attention. Sleep is a very common problem associated with fatigue, and then sort of emotional regulation issues, as well as sensitivity to various environmental stimuli. This diagram is a reminder about how all of those things that we just listed is really a multi-dimensional problem. And all of these different domains feed into those symptoms. So it's important to not just consider one aspect of the presentation, but to look at how do physical health, environmental influences, and psychological health all impact on how their symptoms are presenting and how it's impacting the person. So for example, physical health, as I mentioned earlier, pain being a very common example, but also just things like shortness of breath. If you have chronic pain or shortness of breath all the time, that's going to have an influence on your psychological health as well. Similarly, environmental influences, here a very classic example are just things like financial resources. So if you are recovering from COVID and you can't go back to work, there are financial pressures and social pressures that then will add to manifestations both in a physical and psychological way. So it's this interplay of all of these things. I think that as clinicians, we have to keep that in mind, because treating only one of these types of things is not going to be as successful as coming at it from all these different angles. So one way to conceptualize how patients present to us with symptoms after COVID is to think about, what were the pre-existing conditions or predispositions that patients might have that would put them at higher risk of getting either a longer duration type symptom or a more severe onset. So for example, we know from many studies that pre-existing mood conditions or mental health conditions do put you at higher risk of developing more persistent COVID symptoms. It seems like gender has an influence. So female gender is often identified as a predisposing feature, particularly for some of the psychological sequelae after COVID-19. There are some factors during the active COVID period that can play a role. So for example, those who were hospitalized and developed delirium statistically at least seem to have a higher risk of developing neurocognitive issues. And certainly if they had any actual injury to their brain, such as stroke or hypoxia. I put a question mark behind severity because I think there's still a lot of debate right now about whether or not severity itself plays a role in how symptoms present after the acute period. And I think for the long COVID people or persistent COVID symptom people, severity is actually not necessarily associated. So even though you might think that those who are hospitalized may have a higher risk, reality is that there are many people who recovered in the community, never went to the hospital, that similarly have quite debilitating post-COVID symptoms. And finally, there are conditions that occur after they have gone past the active COVID stage that are perpetuating the sustainment of their symptoms. So, for example, some of the environmental factors I mentioned earlier, such as financial pressures or social stress, in addition to just having persistent or long COVID symptoms that will have an impact. So if you think about it in sort of these stages and how pre-existing risk can increase the likelihood of having challenges with COVID symptoms after acute recovery. I just pulled this study as an example as to how frequently we actually see neurocognitive and neuropsychiatric presentations after COVID. This is a study that was done in Spain in the early part of the pandemic, where they looked at 179 hospitalized COVID patients. They actually screened out already those who were from nursing homes, those who had pre-existing cognitive or brain injuries, substance use issues, psychiatric disorders. So this is a pretty relatively healthy population that they looked at. They then surveyed these folks about 2 months after discharge and asked them a whole battery of different questionnaires. And bottom line is, as you can see here, there is a high frequency of overall neurocognitive impairment of just over 50% in these groups of survivors. And similarly, some of the more psychiatric presentations also very common at close to 50%. The interesting thing was they did identify delirium during hospitalization as predisposing people to higher risk of these symptoms. And again, the female gender was related to a 2.5-time increase in terms of the odds of getting psychiatric comorbidities after. So in terms of general approach to cognitive rehab, because obviously, you know, in the rehab field, we deal with people who have had other types of brain injuries and have similar type symptoms and complaints. So in general, we take this kind of approach, which is, first of all, educating patients and family and caregivers about what it is that they're experiencing and how their particular condition may have contributed to that. It's important to identify focused areas for intervention rather than trying to cover everything at once. And also the fundamental principle of treatment is to help patients self-manage. And we're there to offer them guidance and support, but ultimately the patient actually has to do the day-to-day work on this. And then it's a matter of gradual exposure, building tolerance, identifying where their limitations are in the current time frame, and how to move forward with that. Things like counseling and cognitive behavior therapy are actually extremely important in this group and will help patients become more self-aware. Of course, if you do identify significant underlying medical conditions like depression or severe insomnia that impact their function, we sometimes will look at treating that pharmacologically as well. And then as usual, we refer as well to other specialists if we think there are more problems going on, such as, for example, sleep disordered breathing. We'll refer them to sleep clinic for workup. And the other message, I think, in terms of looking at cognitive rehab is the importance of the ongoing journey. This is going to be a time-consuming endeavor. It's not going to get fixed with just 2 or 3 visits, and you need to be prepared to follow up with these folks on a fairly regular basis for some time. Okay. Hand it over to Evan.
Thanks, Jen. Most commonly, you may have questions like, why do I have these issues? What kind of testing needs to be done? This first statement is something related to what Jen's slide was about, just trying to explain for the first time that it's quite complex related to multiple factors. Of course, a first appointment is always challenging to start some of the education process, and we start simple. And then just trying to reassure about, let's hear the story more, let's do the physical examination, and then we can talk further about next steps. These are some of the things I usually talk about. And the next slide, please, is they usually ask about why or will I get better as well. And I'll show you a study in a couple slides, and then I'll go through a case actually later on, but that's more of an early case. This one is a slide just to say that most studies show that people improve with time, and that's with different domains, including what was mentioned about fatigue and sleep and cognitive issues, but it is long. This slide here talks about a review of many different studies. The challenge is at the very beginning of the 2020 articles talked a lot about the even classifying dizziness and headaches under central nervous system effects. So just look at the percentages with a grain of salt. Some of the studies have shown it's very low in terms of actual cerebrovascular events, less than 2% or so, and more in the severe admitted patients. So I think with time we'll better understand some of these categories about CNS and PNS, but this slide also emphasizes what was already talked about and what was also discussed at the previous presentations for screening for all the mood disorders as well, and quite common to have these coexisting. But then there's some, and I'll show you the next slide as well, about the attention and memory challenges that people have. This was one of the latest ones in either September, October, quite a large review. They screened 1,000 plus, and 66 studies were included. And it was quite high. I mean, similar percentages that you've heard about already, about a third or even 40 to 50% for anxiety, depression, a quarter post-traumatic stress disorder, and cognitive deficits as well. But that seems to range depending on what type of screening they were doing, or questionnaire, or more detailed testing. And fatigue, that was actually, interestingly, one of the ones that prompted more patients to be referred to a COVID rehab center in one of the studies. And of course, sleep, quite a big contributor. I know this is repeated information, but I think we're just stressing the importance of screening and identifying those with premorbid conditions, because I have had people with either depression or ADHD and had challenges with their symptoms afterwards, and then newer issues that may arise. Next slide, please. This question comes from a case that I'll talk about. Is there a workbook I can go through from a patient point of view? I know we as physicians would also want one as well, but this case was talking about, can I just go through a high school textbook? I'm having problems. So like what was talked about for the approach, let's understand what the specific issues are. Is it planning? Is it even attention? Is it just memory or short-term memory? Is it recall? Is it retrieval? Lots of different issues that can happen with cognitive. And then also understand what kind of tasks are needed, either home, work, or recreational. Next slide, please. They're dealing with most of the physical things already, and then now you have this challenge of the cognitive issue as well, with both home and childcare or work or everything all at once, right? Most of them have an idea about what the problem is and have some awareness. This is very important to start. With our more severe brain injury and stroke patients, you can imagine the self-awareness, which is one of the prerequisites, is affected greatly, right? So hopefully we're dealing with more of the milder effects of having great awareness, which sometimes gives us more concern when we feel those symptoms. And then also goal setting. These last three terms are about things kind of like in rehab, we either try and restore or adapt and compensate. And the general category for compensation would be using, let's say, an external cue like a memory book. We will talk about that more in the cases. Internalization is more challenging because we're trying to use things now internally instead of external notebooks or Post-its or calendars or apps and things. And then ideally, you're able to generalize one task to another. Like I've been able to improve such that I can do my bills, but I can translate that to doing some database work at work. That would be more challenging. So it's more of a graded action plan. Next slide, please. Awareness. This is an excerpt from some of my patients who were referred to see me from the COVID clinic at St. Paul's. I have a question there that people are able to input prior to the appointment. How is this problem limiting my function, other than the other kind of basic questions? So you can see here, I'll let you read some of them on your own, and I'll pause a bit here. But I'll emphasize some things such as losing focus, or I struggle with stamina. I'm hoping that some of these comments are perhaps very similar to what they tell you in person verbally. Confidence. I feel like the productive member of society is gone. So the effects are quite great in terms of function, and that's what we deal with rehab, with other diseases as well. This person has to work, take care of the children, drive, but also some other physical symptoms as well, draining, fatigue, breathlessness. So a lot of these challenges I'm sure you've heard about, but I just wanted to share with you some of the patient stories here. Next slide, please. For general things to think about, I think I have 2 take-home points from my part here for the case is about what are the strategies that we may or may not be able to do in a clinical setting. Some of it is more nuanced and done in a therapy setting. And then I'll talk a little bit more about some basic, not basic, but prerequisite of cognitive rehab, meaning having some attention. And I'll describe some of the things about attention. So strategies, I had mentioned, alluded to the word internal, but there's also external. So some of those things that are external, I mentioned about either a memory book or a calendar, some sticky notes, structured systems and planning systems, things that are external to the patient that help cue to remind about things or compensate, or the therapist as well. So these are things that we may need when people are more affected. Ideally, when people are perhaps learning with the external strategies, and maybe milder cases, they can begin to do internal things. And self-drainated procedure would be these cues with visual imagery or mnemonics that they would use. So something that they don't rely on external to the person, so it's internal. So you can imagine that it's under more conscious control, and it would be more difficult for those without a structure or awareness or enough training yet. So I just put this here just to educate ourselves, and then hopefully also use it for our patients when we give them some examples. Next slide, please. So which category might these people in the clinic might fall into for cognitive? I think Jen had alluded already or talked about the general symptoms, but in relation to what I just talked about, having some mid to high self-awareness. People talk about decreased, they can't focus, they can't remember simple things, short-term things, and slower to process. And most of them want to improve, and they have large or global goals and plans, like many of our patients with either pain or injuries, but it's limited in terms of breaking it down to shorter term goals. So goal setting is quite important. We keep things long-term goal and try to break things down into months or weeks, or even what can you do in the next day. And then I'm sure you've seen your fair share. I've had people needing to take care of a demented partner or partner with dementia, sorry, and at work still haven't taken time off work, or they have children, or they have just recreational activities to do. So this is most of the kind of characteristics I've seen so far. Next slide, please. This case here is a recent one I've only seen or talked to once so far, but just giving you an example of what's kind of some of the first steps. Mr. Trainer, I call, because he is a personal trainer, but also manager of some facilities requiring some administrative roles, fairly independent and quite the exerciser you can imagine, including high intensity workouts, the last one done prior to COVID, presenting with symptoms at the end of 2020 and positive January 2021, non-hospitalized. And most of the residual symptoms included the shortness of breath, headaches, what he described as brain fog, and had actually worked with the St. Paul's physiotherapy to help some of the physical activity issues. Of course, not at the intensity that he was able to do before, but feeling comfortable with that plan in terms of looking at my heart rate, how do I progress? I'm a personal trainer, I know that type of thing. What he had challenges was just even Microsoft Excel couldn't input things 10 minutes before getting a headache, and trying to multitask with cooking a complicated meal to make sure things are all, he said, done at the same time. So because of a personal trainer, so this type of a character is someone who is aware, who has some experience in progressing, but more physically, is very interested and dedicated, and looking to something to do for the brain as well. Next slide, please. So is there a way to, you may hear about exercise, rehab, and strengthening time and attention and progressive overload. Can we do that cognitively? That's something that was in that slide about gradual exposure and building up the tolerance. And his question was, isn't there a grade 11 textbook I can go through just to understand that? My answer to that was, I needed to better understand the tasks. And I think we have to talk about that at the next appointment, because there still was an interest in this, which we do have to, I think, understand. We have to look at the strengths of our patients to see and their interest, right? And is there harm in that? Perhaps not. But the research in terms of neurorehab, the generalizability of things is very challenging. You may remember maybe 10 years ago, plus the luminosity games and things, and people got very good about the attention and things there, but it did not translate very well from typical functional tasks. So can we do something with type, intensity, duration, all these different parameters we do with cognitive rehab? Next slide will focus a little bit about just a basic attention, because there's a lot to go through with cognitive rehab. And I think this may be helpful. It was helpful for me, and to hopefully review with him next time. So at the most basic level, there's actually focused attention, ability to recognize either visual, tactile, sensory, hearing inputs or stimuli. But then looking at him, for example, sustained attention, data entry by itself. That's it, nothing else, simple translating one to another. And it's literally just the keypad, enter, tab, keypad, no distractions, nothing. Cooking one dish only, one pan, few ingredients, very simple, right? Alternating attention, which we may deal with on a day-to-day basis in terms of interruptions with phone calls, emails, at work while you're trying to do a task, or you're trying to cook, but you're trying to make sure the little one doesn't get into some danger. Or there's selective attention, trying to do things, but there's a big construction outside, or there's blaring music in the office, and you're trying to focus. So selective attention is you're trying to process the target info quite selectively, and you're trying to inhibit the rest of it. And then there's the divided attention. So a bit more complex, so you're trying to respond to a few stimuli at the same time, or it's quite complex to do, or you're trying to do so many things like a 5-course meal and trying to time it all within an hour and a half or something with the time and the task. So the hierarchy here is in terms of the focus attention first, can you even respond to the stimuli? But sustain, then can you alternate, selective, divided in terms of complexity? So trying to use this, I think, as a framework to, one, educate, because that's one of the first plans of many rehabilitation consultations is education about diagnosis, prognosis, and then what can we do. Next slide, please. For this case, I'd like to bring him, I'm still waiting to have him come back in to educate about the different types of attention in relation to the tasks. So with that, he had difficulty transferring numbers on a table in Excel. So it's data entry, I think it's sustained unless I hear otherwise in terms of some of the distractions that it may have. He talked about needing to rest 30 minutes and things. So how do we use this to advantage that it can be done, but there's some symptoms? How is it related to the physical activity and exercise issues that he had as well? And then multitask was something that sounded a bit more complex, and he had great difficulty in that. So it might be more complex. We have to explore if that resulted in more symptoms as well. Next slide, please. The last appointment, I suggested the PHSA website. I think we do have some links and screenshots at the very end, and also some symptom journaling to build some awareness about some of the symptoms, both from physical, emotional, and cognitive side. That was the homework for now. He was to see the occupational therapist, but I think that is still pending. There were some resource limitations within the hospital, and then follow-up still pending. So we'll talk a bit about the education about attention, and hope you can use that as well to better understand the tasks that your patients are trying to do. Most of the time, people are trying to do too much, I find. And we're trying to do some broad, simple to complex, breaking them down. And then if I know it would be limited in the office, but is there any role for attention training or task-specific things that the therapist may take them through, or is it enough for us to work on some basic goal setting, attention, and graded exposure? Time will tell for this case.
Thanks, Evan. So that's certainly one case illustrating a fairly high function individual who already has some concepts about training and how to progress in that way. Here's another case example to try and illustrate some of our approaches to the symptomology. So this is Steve, who is a 55-year-old gentleman who was previously active and independent, tested positive for COVID about 3 months ago, a brief hospital stay, fortunately not requiring ICU. And now he's coming to us in the clinic with a number of difficulties, and as you see there listed. So again, very common complaints. One of the things he does have problem with as well is with computer screens and essentially with concentration. He can't really work on a computer for more than about 20 minutes before feeling really tired and just can no longer focus. And this is having some impact on his mood as well in terms of irritability and frustration. So one of the first things that I usually try to do is, as I'm learning about the symptoms from the patient, is I'm asking myself, like, what does it sound like is the most disruptive symptom? What is the most significant symptom? And sometimes I will even ask them, okay, if you can name the top 2 or 3 things that you'd like me to fix or you think would make you feel better, if those were taken care of, what would they be? Because, you know, with this big list of symptoms here, you can't tackle them all at once, particularly if you're in a family practice setting. You really only have a very limited time to try and do something to help this person. So first thing is to try to focus it down onto things that you think will make a bigger difference. The other question that I think is important as I'm listening to the patient is, what are they not saying? So patients will come to you with their active complaints, but sometimes underlying that, they're really expressing their fears. And they often have a fear about not being able to go back to work or being normal, as they call it. There's a lot of uncertainty about how long this is going to take, if they will get their functions back to their previous level or not. And essentially, there is a whole feeling of loss of control, of not being able to help themselves. So it's very important and helpful, I think, to acknowledge this with the patients, and it helps you build that rapport that you're going to need as you work with the patients over time. So the impact of those symptoms on Steve, of course, is multifold. Not only does it have an impact on his work, so on his vocation, but on his family dynamic. So this is creating stress in the family and with his children. There's a growing sense of social isolation because he's not able to return to not only the work environment, but the social environments, recreational things he used to do. And because he's not back at work, there are quickly building financial pressures. And so again, going back to that whole feeling of uncertainty regarding the time frame and the degree of recovery. So just a little reminder there about all of those interplaying dimensions of how these symptoms present themselves. So if I'm always thinking that, you know, in rehab, we have the luxury of being able to spend a bit more time with these patients to review their history and their overall functional level. But if you have very limited time, I think these are probably the things that you can try to get done within that first 1 or 2 sessions or meetings that you might have with your patient. One is to validate that what they're feeling is real. For some of these patients, they really feel like, you know, this is not them and nobody else can kind of see what they're feeling, and they can feel very alone. And it's important for them to hear that they're not, and to reassure them that this is something that we recognize, and you can see how much problems this is causing them. Next then is, as I mentioned earlier, is can we focus down on just a couple of things that we can try to address first? And then finally is to say that, you know, a lot of things feed into each other, like those bubble diagrams I showed you earlier, and to provide that education to the patient. But you want to empower the patient that they can actually do some things to help themselves improve. And it will take trial and error, but you are going to work with them on devising some of these strategies and helping them improve over time. So typically, if they have problems with sleep, mood, or physical things like pain as being one of the major issues, that's where I would start. Namely because these really have so much impact on everything else. If you are not sleeping well, constantly tired, then your memory is not going to be good and your concentration is not going to be good. Everything gets worse when you're tired. So those are some of the basic things that I will look at tackling first. Similarly, if mood has become a much more prominent problem or even anxiety, then that has to be dealt with as well. And sort of physical things that might be holding them back are also things that I will look at as usually one of the top things to address. And once those are sort of more dealt with, you can then look at some of these other symptom presentations. And of course, if one of these becomes very prominent, then you can certainly work on one of those as well. But generally speaking, if your mood is bad and you're not sleeping well, totally tired, then you're going to have memory and attention problems, and you're not going to feel like yourself. So if we look at sleep in particular, so sleep disturbance is quite common after hospitalization and certainly post-COVID. You can see both insomnia as well as hypersomnia. I would say probably insomnia is more common than hypersomnia. And if they're having trouble sleeping, people often actually have pre-existing problems with sleep. You want to get a sense of, is this a latency issue? Or is this more of an early awakening issue, or both? And I've just listed some of the things that I would typically try to counsel patients on, even prior to talking about any pharmacological type interventions, on how they might be able to improve their sleep. So there's lots of stuff out there on sleep hygiene, almost too much. Sometimes people have to just pick a couple of things to start with. We want to make sure that their sleep environment is reserved for sleep and that it's not overly stimulating, etc. There is the whole concept of sleep debt, which is you need to build a certain amount of sleep debt before you can try to get a good quality sleep. So if they're waking up in the middle of the night, the idea is, if you're up for half an hour already, then don't keep laying in bed. Get up, do something quiet or whatever, and don't nap during the day, even if you might feel tired, because you want to restrict that sleep during the day to build that debt so you can hopefully sleep better again at night. You want to certainly eliminate things like alcohol, which we know will disrupt sleep actually. And there are some very helpful cognitive behavior strategies and approaches for insomnia. There's particular ones for insomnia that that you can look at for patients. Physical exercise, we know, will definitely help with sleep quality. So depending on their physical tolerance, you want to make sure they're getting at least some degree of physical activity, hopefully on a daily basis. And then, of course, ruling out sort of comorbid things like sleep disordered breathing that may be interfering with the quality of their sleep. I will consider medications in people who are having a lot of insomnia issues, especially if there is something you can give them as what I call a 2-for-1. So if they're having pain as well as sleep issues, you can often start looking at things like potentially a tricyclic antidepressant for that. Or if they're having mood and anxiety issues, then you can look at also things like mirtazapine and other medications that may have benefit for more than just sleep assistance. So looking at then some of those brain fog type complaints. So brain fog is such a general term, but really encompasses many features that you see here. So just like Evan did earlier, we try to focus in on one or two of these things. So it might be concentration or attention, and then looking at specific strategies on how to deal with that. Generally speaking, we discourage people from multitasking because it tends to not work out very well, especially in the early stages as they're improving. And I think the other thing that I emphasize to my patients is that they have to give themselves a break. They often compare themselves to what they were like before. And so they'll say, well, I used to be able to work like 4 hours in a row and I didn't have to take a break or anything. And so my response to them is, what, don't Don't compare yourself with that all the time. Compare yourself with what you were like a week ago or 2 weeks ago, and use that as your benchmark and motivation for moving forwards. This is going to take time, and it's not going to be perfect, and you will have fluctuations, and you will expect to have sometimes bad days, and to not let that deflate them, because sometimes people will feel like, oh, it's, you know, it's all coming back, it's not getting anywhere. But to expect that you may have some bad days, but you know what, that's okay. You're going to get back on the horse again and continue to move forward. This is just a concept I think have been mentioned before as well in previous ECHO presentations, in terms of the activity zones and where we'd like people to work within. So it's the concept that be it cognitive or physical activities and energy level expenditure wise, you have sort of a comfort zone where you feel comfortable, you got lots of reserve. Then there is a therapeutic zone where you're kind of doing things that are a little bit more demanding, but you're not yet completely exhausting yourself. And then there is the what's called the overdoing it zone, which is at this point, this is going to strain you. This is when you've been spending too much time in this overdoing it zone. Patients will say, you know what, I then crash. I crash for like 5 days afterwards. I can't do anything. So the idea of where is the patient in this these energy zones, and we're trying to encourage them to work within that therapeutic zone. And for some people, this therapeutic zone can be very thin. It doesn't take much to push them over into the overdoing it zone, but they need to do some work to figure out where are they? What kinds of activities will lead them into one level or another? So this is a document you can find on the PHSA recovery site. We'll show you later as well. And it goes into a lot of detail about how you can think about your activities and the energy requirements to do them. And that applies to not only physical type activities, but also cognitive and emotional type activities. I don't certainly expect every patient to go through this and score themselves all the time. Not all patients will be able to do that. But it certainly can give you some guidelines as to what kind of things might be more demanding, and to spread those kinds of activities out through the day or through the week. In terms of energy and fatigue management, we usually have the 3P approach, which is to plan, pace, and prioritize. And this is, again, not unique to post-COVID, but also to essentially any condition that causes chronic fatigue. So these are just some ideas to give patients about how they can enact the 3Ps. So looking at distributing their tasks and activities, how they might alternate things, how they might pace themselves, and taking breaks, which is an important aspect of this, as well as prioritizing. So what really has to be done? What are the important things versus the nice to do things? And who then at the very end, of course, is, do you actually have to do it, or can you delegate it to somebody else? So in this case with Steve, he's got a limited screen time of just 20 minutes. And so usually I will start with, you know, what are you doing for those 20 minutes on screen? Are you reading something and trying to do something very intensive, or is it pretty easy stuff? And certainly we want to start with easier tasks that they can handle. They may even want to encourage him to break up the 20 minutes into 10-minute segments and then have a little break in between. So the idea here is you're trying to gradually increase that endurance that they spend in front of the screen. They can modify the task to make some things easier, but remember to stay in that therapeutic zone if possible. And to see how does this particular activity fit in with the rest of what they need to do for the day or for the week. In general, when I look at gradually progressing somebody's activity or tolerance, I look at frequency first, and then the duration and the intensity of activities. So I'll ask them to, just do this exercise for, twice a week. And then as they get comfortable with that, now let's try it for 3 or 4 times a week, and so on. For those who like to use some kind of a tool to document their plan. This is a generic self-management action plan. I think there is something similar on the Self-Management BC website as well, but it helps patients to document and track what it is that they are working on. So it goes into details about what it is that they're trying to do, how might they overcome barriers. They rate themselves in terms of how important the activity is or how confident they felt doing it. And then there's sort of a self-reflection piece as well. And this not only helps them plan, but it helps generate insight. And it gives them something to look back on to say, you know, I did the same activity 3 weeks ago and I didn't feel like I did it very well, but now I can see I'm doing it better. And so that's the benefit of doing some of this tracking. So after that first sort of appointment with the patient and understanding their issues, it's important to have follow-up. And this can now be more sort of virtual or even a call. Essentially, you're acting as a bit of a coach to kind of help them through some of these strategies. And again, to tell them to don't sweat the days that are not good, to expect some setbacks, and that this will take time. To celebrate the successes, I notice that patients sometimes don't actually recognize their success. And I remind them, I say, you know, I remember when I saw you 3 weeks ago, you could only do this for 10 minutes and you're now able to go for 15 minutes. That's an improvement. It may not seem like much, but that's better than where you were. So even recognizing the small steps in progression is important. And finally, you know, Personally, I think it's important to meet the patients where they are in terms of their ability and their capacity. And I think a lot of them already feel like they're being judged about whether or not they are a capable person in one way or another. But the idea here is to kind of say, you know, let's not worry too much about what used to be, and let's look at where you are now and how we can progress from there. So the multidisciplinary approach that as physiatrists we usually take involves other people. This is a complex problem, and if you can get some of these other health professionals to assist the patient as well, it can go a very long ways. And so these are just some of the disciplines that we certainly often turn to. Now, knowing, of course, not everybody have access to these things, but if you can get some access, these are the type of tasks that these individuals can help you with. So, for example, an OT is often very helpful in that they can actually do much of the more detailed work with patients on planning, pacing, and so on, and also developing strategies specific to their issue. Things like social work can help them a lot in terms of navigating some of the benefits and the paperwork that they might have to go through, which can be very challenging at the best of times. And if you have access to vocational rehab, sometimes through WorkSafe or other means, these people are very good at looking at planning graduated return to work schedules, and also in terms of looking for accommodations that might be helpful in the early stages of return to work. So the big question is, well, how do you access these people? They are, you know, few and far between, not easy to get. There's often a long wait list, and that's a reality of our current healthcare system. But I usually will try and find out, do they have any access for private funding for services, be it from their extended benefit or if they have their own personal financial means to be able to access that. That's probably the easiest way to go, and you can get service the quickest. Employment benefit programs like EFAP typically have some psychology and counseling services associated with that, may be useful if the patient can access that. Community services are there, but they vary depending on where you are. And also they tend to address more the acute needs, the safety needs, as opposed to ongoing therapies. So it may be a a place to go if they're really struggling and you're worried about them. But eventually that usually have to fall off after a little while. And then of course there are rehab centers like where Evan and I are, for those who have more severe or complex interplay of these challenges. But there are significant wait lists for these resources as well. WorkSafe, if they actually, potentially contracted COVID at the work site, they may be eligible for WorkSafe benefits, and WorkSafe is actually pretty good at providing some of those other health professionals upon recommendation from the physician. And currently with our post-COVID-19 clinics, we are looking at how best to use the resources that we've been provided with to help our patients. So that's under development in terms of how we'll be able to allocate those out to our patients in need. So there are lots of good online resources, and some of you have probably seen this one already. It's from PHSA. And if you go into the care and recovery section or just Google PHSA COVID-19 care and recovery, you'll come to a page like this. And there's lots of tools in there that you can look at or print out or show your patients that you can use directly. And you're certainly welcome to do that. These are all free resources for them. Another good site to look at is Self-Management BC, which actually was created for all kinds of different chronic conditions, but they have some modules that might be helpful. They have self-management programs and tools like the action plan thing that I showed you earlier that again may be helpful for patients to follow. And this one, which was headed by physicians, I believe, in Victoria, but it's province-wide now. This is the Cognitive Behavior Therapy Skills Group that's led by physicians who have been trained to do group education and group CBT, usually a group of 16 or less. It's an 8-week program, and it's a synchronous online program right now. So they do need to have some technical capabilities to join in. They do actually charge a $65, it's a no-show deposit. So as long as you attend at least 7 out of the 8 weeks for your program, you get your $65 back. So it's just incentive for people to follow through on that commitment. But it provides education on psychocognitive issues as well as mindfulness practices. So I think we're going to stop there. Hopefully that was giving you some ideas about what you can take with you to implement in your own practices. But I think I'll open it up now for any questions. Evan, you can unmute yourself and see. Let me have a quick look through the chat box too. If there are any questions, you can certainly feel free to ask. I don't know if they can unmute themselves, but you can certainly also post it in the chat box.
Hi, it's Brenda. Can you hear me?
Yes, please go ahead.
Hi, it's Brenda Hardy. I'm family doctor in Vancouver. I just have a question about, are you aware of any ongoing research into this area? It just made me think, when I first graduated from medical school, we used to treat asthma with breathing exercises, Ventolin, but we never used steroids. It was not a thing at the time. It was very, very scary. And now, of course, asthma treatment's sort of been flipped on its head. And so as I was looking through some of those self-help things, I'm thinking, certainly these are symptom relievers, things we can do to help people help themselves feel better. But it kind of indicates to me that we don't actually know what's going on. We don't really understand this very well. There are no other therapeutic options besides symptom management. So I'm just wondering if you're aware of any significant research that's going on anywhere where we could be directed to look, to watch, to see what might be coming.
Evan, do you want to address that first or?
Oh, sorry, my microphone there was on the top of my ear. Yeah, there's always ongoing. I think the challenge is, yes, absolutely. There is a symptom base, but it's also looking at the literature. For the one that I saw in terms of the systematic review, it followed up to people up to about 7 months. It wasn't clear the limitations of those studies about whether or not it's direct or indirect effects of the COVID infection, first of all, but also when they followed, there's still variability in terms of improvements over that time frame for those large 66 numbers of studies. I think one of the questions that we were looking at as well, Jen, when some patients ask us, how about an MRI? What can, for these neurological symptoms? So there is still ongoing research from what I understand about the effects on the brain, if any. Is it from severity, from hospitalized or mild? Not clear. They're looking at whether or not the olfactory tract going into the prefrontal and the hippocampus and the different areas connected to the olfactory neurological system are affected. And I don't think it's clear, although there is some literature about are there some microischemic issues going on. But even as such, even with our stroke, should there be something like that, we do rely on the cortical neuroplasticity. And then these measures are, of course, rehabilitation as well as symptom management. I think a lot of it that Jen alluded to was more about the symptoms of the sleep disturbance and things. And then I'm not aware of the publication yet, but I am sure your patients have gone through the large cognitive kind of survey that came out of Ontario. I think early on, people were being followed 3 months, 6 months, 9 months in terms of surveys, but that is more of a kind of functional cognitive, more detailed examination. Related to that, there are some European studies about ways of identifying the domains and then trying to see if these different kinds of apps and programs can help with their recovery. Some of them have been used in autism, from what I understand. So yes, there's ongoing research about first the cognitive effects. Second, is there any brain neuroimaging issues? And then ongoing following of resolution slowly of symptoms and what we can do to support symptomatically and with rehab strategies. Jen, did you have anything else to add?
No, I think that's my understanding as well. I think, there's no question that we do not fully understand this. We don't know, is depression caused by COVID any different from depression from another source? We do not know that. And so I think we end up taking sort of a similar approach, assuming that they have some overlaps at least. But definitely there's ongoing work, I think, happening in this area from many different sources, and we will learn more over time. So I see there's a question in the chat box about what programs are publicly funded that family physicians can refer to for physio, OT, psychological, social work, et cetera, in each health authority. I think that's really the million-dollar question. Each health authority is a little bit different. So even the post-COVID clinics, for example, the one in Fraser Health versus the one at VCH may have some slightly different resources and criteria. But there are some of the services that have been allocated to those programs. We're in the middle of trying to figure out how people can access that, because there's not enough for everyone to have one-to-one therapy, but there may be opportunities for group education or group sessions and whatnot. I would say that if they have really more significant disabilities, clearly, if they actually had like a stroke or something like that was associated with their COVID infection, then that can get referred to a regular outpatient rehab program in your health authority, and be able to be picked up by sort of what we have in terms of general rehab programs that are already in existence. Psychological referrals are always very difficult, but most of these are private funded, and there's essentially not much in terms of MSP coverage for that in most health authorities. And that's why we were, referring you to some of the online type things that you can access. But
mindful of the time. Unfortunately, we've run out of time. I'd like to thank Dr. Kwong and Dr. Yao Also, a reminder for anybody who needs CPD credits from UBC, please put your name and email in the chat function. You'll get a post survey, so please take 2 minutes to fill it out. And the next session will be on November 29th, again, from 12 to 1. And the topic is post-COVID-19 support for persistent disability programs and required forms by Dr. Jill Calder. So stay tuned for registration. Thanks, everybody.
Thank you,
Thank
Rick.
you, everyone. Thank you, Rick.